Good evening and happy Teach Me Tuesday. I'm Lisa Houston, and today we are going to talk about care of the late preterm infant. So let's review. What is the definition of late preterm infant? It's like, why can't we just have like preterm infants and term infants? But we have preterm infants, late preterm infants, term infants, and late term or post-dates infants, right? A wide variety of kind of definitions. So when we're talking about the late preterm infant, we're talking about those babies born between 34 and 36 and 6/7. Kind of before 34, you're considered preterm, and after 37, you're considered term. So 70% of all preterm births are late preterm. They are at a greater risk for medical problems, including a 7-fold risk of morbidities. And a lot of that is because they appear similar in size and weight and just their overall appearance to term infants. So we tend to treat them like term infants. But in reality, these babies are not just smaller term infants. They actually, if anything, are bigger preterm infants where they have many of the same problems. In fact, when I was creating this slide deck this week, I was really thinking about how it's similar to last week's slide deck about the golden hour on the small baby admissions, and that if we can really hone in on a few body systems and a few things that we can control and pay extra attention to, that the late preterm infants actually do pretty well. So we're going to talk through some of those today. So what are those things that can go wrong, right? Even though they look like term babies, they're actually at risk for many issues that can happen. Hyperbiliary, respiratory distress, infection, blood sugar, glucose problems, developmental issues as they go on. So let's break each one of these down. My favorite topic? No, the placenta is my favorite topic, as we've talked about, but thermoregulation is right up there because when we think about how important thermoregulation is from every single baby that we take care of in the NICU, and it's something that we as bedside nurses can control so easily, it is empowering to know that some small thing that we do can really make a difference. So when we think about the late preterm infant in regard to problems with thermoregulation, we think about their decreased brown fat stores, their decreased subcutaneous fat, their decreased glycogen stores so they can't produce their own heat, and their profound susceptibility to heat loss. I remember my son was last year in science class talking about like convection and evaporation, and I was like, oh my God, those are all the things that we talk about in the NICU in relation to issues that can happen in regards to thermoregulation. So this is something that can happen even in those late preterm infants. When they don't have quite those fat storages on them, they're very susceptible to swings in their temperature. And as you probably have guessed, once their temperatures are changing, then their respiratory status is changing. Their blood sugar is being used up to keep them warm, and then they have low blood sugars. So often, if we can keep these babies warm in mom baby or your nursery, wherever you're keeping these babies, they often will do pretty well and not have issues with other body systems as long as we can keep them warm. So our clinical management of that is those frequent assessments. We know that getting those babies on skin to skin, some hospitals have what they kind of call their newborn hour, where the babies are with their mom on their skin for the first hour, where they are not weighed, they are not measured, footprints aren't done, they're just right on the mom. And we can still be assessing the temperature during that time. But once they come off there, are we swaddling them appropriately? Are we keeping them away from drafts? If they end up needing oxygen, making sure we're giving them that humidified oxygen to help keep their temperature up. But that brings us to respiratory. So the respiratory system is one of the last to mature in utero. It happens even up until they're 36 weeks corrected, which is also when we talk about apnea of prematurity, which is often a time that we can see it happening till. One of the big things that happens during the third trimester of pregnancy is a surge in surfactant production. So you can imagine that if these babies are missing that surge, that there could be a delay in their maturation. During their transition to extrauterine life, their body may not transition as well as a term babies will, which will increase their risk for having respiratory issues. They also have muscle maturities, right? Their muscles just are small and they're weaker. It's kind of like those decreased brown fat stores. They just don't have what they need quite yet. When we think of that from a nursing perspective, if we kind of compare those two things, the transient tachypnea of the newborn, or TTNB, versus RDS, respiratory distress syndrome. With TTN, often we just need to give some CPAP, get some positive pressure ventilation going in there, get them into a good position, maybe get them on their belly, allow them to have some expansion in those lungs to help complete the transition from intrauterine to extrauterine life. If they have respiratory distress, they may need supplemental oxygen and absolutely might need some surfactant administration to help with that thing that they missed. We talk about babies, preterm babies, missing a surge of vitamin D and calcium for their bone growth, but also they're going to miss this surge of surfactant production, so their lungs just aren't going to be quite mature enough. Infection. They are still preterm infants. They still have an immature immune system. They've had a decreased transfer of those maternal antibodies from mom to baby. Their skin integrity is not as intact as a term baby. So we still need to monitor them closely. Most places have kind of like a late preterm protocol, how often you're doing your vital signs, how often you're checking in with the baby, whether that is, again, is in a newborn nursery, on a mom-baby floor, postpartum floor. Make sure that these babies are getting their RSV immunizations and any other immunizations that they are needing. If they are in the NICU, that they are having CLABSI prevention. We also talk about the, don't kiss the baby, so that we're not having the passage of those viruses between visitors and the baby. And of course, practicing hand hygiene, because we all know that hand hygiene is the #1 way to prevent the spread of infection. It's one of my favorite words, hyperbilirubinemia. Ranks up there with the medulla oblongata. But hyperbilirubinemia is especially risky in that late preterm infant because they aren't being checked as closely, and they may often not be getting the optimal hydration that they would need to push some of this bilirubin out of their system. They have immature guts. In addition to that, they might have poor latch or decreased tone that causes poor intake and poor feeding. We also may not be feeding them if they're in the NICU. They may be getting those very small volume of feeds, whether it's a colostrum or small formula feeds. But because of that, they are not getting this surge that they need, because the large amount of the bilirubin is broken down in the gut, metabolized by the gut, and sent out with the stool. So if we don't have food going in there, or enough food, and then you have this immature gut that cannot quite process what's coming to it, you can see how quickly the bilirubin will back up. These babies need close transcutaneous monitoring of their bilirubin, watching their latch, getting lactation involved, getting therapy involved to make sure they're getting adequate intake, early feeds, getting supplemented feeds as needed, even if it's in those first few days to get the gut moving. And then obviously starting phototherapy. There's lots of great tools in the charting system we use. There is kind of a built-in Billy tool where it looks at the risks, the hours old the baby is, but you can also go to billytool.org and plug in how old your baby is in days, hours, weeks, etc., and what their bilirubin is. And it will tell you what their risk is as far as hyperbilirubinemia and if they need to get the lights. And then making sure, of course, if they're on phototherapy, that we are covering their eyes and then giving them light breaks during cares. So their blood sugar is another big thing that can go wrong very quickly in the late preterm infant. And some of that has to do with the same things we just talked about with the bilirubin, right? They may have poor latch. They may have poor swallow, poor feedings, poor tone. We talked about muscle tone with respiratory as well. So then they're just not getting the milk in that they need. But add to that they have low glucose stores with increased glucose utilization, especially if you're talking about thermal regulation and the baby trying to keep warm. So you put all that together, and then you've got this developmental outcome as well, where they have that immature oral motor development and coordination in order to get their sex swallow breathe going. You can see how quickly we can set these babies up for failure if we are not adequately watching what they are doing. So this might mean frequent checks of their blood sugar. Maybe they're going to be AC sugars times 3. Maybe it's AC sugars for the first 24 hours. So whatever your hospital protocol is making sure that you get in there and get those sugars done quickly. Really monitoring their intake is going to be crucial in the late preterm infant. We can talk about it in the number of wet diapers or stools, but also really watching for the latch. Is the mom's milk coming in? If the baby's taking from a bottle, are we giving them the amount that they need, but also not too much? Are they waking up so that they have time to get these feeds done? And then, of course, teaching our parents the signs of a successful feeding, having them watch the latch, the moving of the jaw, the swallows that the baby's doing to make sure that the baby is going to transfer that milk successfully. And then we have those developmental factors that lead to some of our issues with late preterm infants. So they have the incomplete development of their central nervous system. Just like a preterm baby, they've been born early. They don't have every single thing in place that we would want them to. This causes an altered response to their environment, but a big thing that it is doing has to do with their tone. That is going to have them sleep more, not wake up for feeds, have a poor latch, increase their fatigue, not be able to keep themselves warm. So then you have your thermal regulation issues. So these babies really are not just these small term babies. They are just bigger preterm infants who have many issues with their developmental outcomes. And if we can't treat their low blood sugar soon enough or their thermal regulation, they will have profound long-term outcomes, comorbidities that happen to these late preterm infants. It's imperative that we make sure we are on top of our assessments and getting our babies the treatment they need to be able to help them be successful. So developmental positioning, monitoring their weight gain, watching for the signs of poor feeding, making sure they're having awake times, making sure the baby's getting up and being awake and interacting with their family. So to recap, it's important to remember that they are at risk for many things, but if we can monitor their latch, their intake, their output, their temperature, and the blood sugar, they're going to be very successful and transition successfully to home. Hopefully avoiding a NICU stay if it's not part of your automatic admission criteria. Some places admit less than 35 weeks, some are less 34 and under automatically. Some have kind of transitional nursery type areas where the baby can go for 12 hours to be able to watch these things closer. But no matter where the baby is, it's all of our job to make sure that we are watching all of those things and then educating parents on knowing what to look for at home. Making sure that the baby is having 8 wet diapers, that they are latching well to the breast, that mom feels that as her milk's coming in, the milk is emptying, that they are awake and having periods of awake time, that their tone is not floppy and loose all the time, that they have periods of high tone where they're able to spend time latching and interacting with their family. So if we kind of assume that that late preterm infant is just a big preterm infant, we will successfully be able to transition them home safely with their parents. Thanks. See you next week.